A warm welcome for the Indian College of Anaesthesiologists webinar. It is the second of series of the research-related webinar by Indian College of Anaesthesiologists, the essentials of research and publication. Our heartiest thanks to the Indian College of Anaesthesiologists to take up this important session. A special thanks to Dr. Radhakrishnan, Dr. Jayashree Sood, Dr. Baljit Singh, and all the ICA members and trustees who has taken this initiative for regular webinar, and also for taking this topic, which has become an essential component for majority of us, whether we are academician, researcher, or clinician. So my heartiest welcome to all the chairpersons, the faculty members, and all the participants. So may I request Dr. Jayashree Sood to give an introduction and welcome note. Ma'am is the CEO of Indian College of Anaesthesiologists. She is one of the great personality in academics, clinics, and research, and she is heading the department at Sir Gangaram Hospital, New Delhi. Over to you, ma'am.
Thank you, Rakesh. Good evening, everybody. On behalf of the Indian College of Anaesthesiologists, it's a great pleasure to be hosting this webinar today with such luminaries as chairperson, moderators, and speakers. And we are really happy and honored to have you all with us today on the same platform. The topic, essentials of research and publication, as Rakesh said, this is the second module that we are having. We had the first one about 3 weeks back, and the feedback that we got from the students was excellent. And definitely this webinar today is also going to be a real hit, especially not only for the students, but even us who as PG teachers have to make sure that our students learn the path of research and publication. Every time they come, that thing is the main thing, the thesis, and we ask what is the research question, and these data and analysis, etc. Everything has to be done. And in this webinar, such important topics have been chosen, and there's no end to research and publications, and it's so important for the students to know which way, which direction to go, how to understand it, so that then they really are interested in research, not only for their thesis purposes, but later on also as young budding anesthesiologists. So it's my great pleasure to welcome all of you. And thanks, Rakesh. Please go ahead.
Thank you so much for the kind words, ma'am. And we have very eminent chairpersons for the day who holds a good responsibility as editors of various journals. And they have a good repute in not only as a clinician, but as a wonderful researchers also. So for the first session, we have Dr. Deepak Govil with us. He is the Director of Critical Care at Institute of Critical Care and Anesthesia at Vedanta, the Medicity, Gurgaon. He is the President of Indian Society of Critical Care Medicine. And I know him personally. He has a great contribution for increasing and sharing the academics at various platforms. He has a very big CV, so I think I will request him to take this session onwards. And along with Dr. Govil will be Dr. Bharti Wadhwa, who is one of my teachers who has trained me during my MD times. She is professor at Maulana Azad Medical College, and she has many academic achievements. She is actively participating in disseminating academic events at various platforms. She is a member expert of Specialist Board of Anesthesiology as National Board of Examination, and is conducting various webinars for the benefit of DNB students. She also holds many respectful posts at various platforms. So I will request Dr. Bharti Wadhwa and Dr. Deepak Govil to take up the first session, please. Over to you.
Thank you, Professor Garg, for kind introduction. So our first speaker is Dr. Pradeep A. Dongre. He is Assistant Professor in Department of Anesthesiology, ESIC Medical College and Postgraduate Institute of Medical Science and Research at Rajanagar, Bangalore. He has got many publications to his name. He is reviewer for Indian Journal of Anesthesiology, the Airway Journal. He is Executive Committee member of ISA Karnataka and All India Difficult Airway Association, Bangalore. He is Expert Committee member, Board of Studies at Rajiv Gandhi University of Health Sciences. So without wasting much time, I request Dr. Pradeep to start, please.
Good evening, sir. Thank you very much for the kind introduction, and I would like to thank Indian College of Anaesthesiologists for this wonderful opportunity for me. And today's topic for me that has been given to me is about research question and research hypothesis, how and why. So, and I bring warm greetings from ESI Medical College, and I also thank Dr. Rakesh, Dr. Sanish, who have been going through this program with such magnificent success. Thank you. So first of all, let us see why we require a research question and what is a research question and why research hypothesis is important to us. So every clinical research project starts with what we know about the current practice, and what we know about the current practice and how where the lacunae are in the current practice that is being followed. So it is in turn there is a quest for a newer practice when we do a clinical research project, and then we need to turn a clinical problem into a research problem. That's actually what we need to do. Yeah. So what is a research question? A research question is a question that arises out of a perceived knowledge deficit in an area of interest. So usually there is an area of interest. It may be, there is an area of interest, and the research question is your initial step while formulating that part, and it just defines what you are interested to know in a subject. So let us say you're interested in pediatric anesthesia or epidurals in pediatric anesthesia. You can go ahead and frame a research question. If something is interesting to you about epidurals in pediatric anesthesia, you may want to know about that in detail, or you may find some area of it interesting and having some lacunae in terms of knowledge, and you may try to improve that in your research project. And the first step in formulating that, your research project, is your research question. So the subject of interest can also be a shared one. It need not be your own subject of interest. It may be a shared one with your peers. It may be a shared one if you're doing a thesis. It may be a shared one with your guide. Your guide may assign a topic to you. You may take a group of topics to him, a large number of topics, and he may select a particular topic from that. So it may be interest, research interest to your guide too. It need not be your own. And why do we require a research question? So that's the most important part of framing a research question, and why it is done in a methodical manner. So you need to identify the problem you want to study. Let us say, as I mentioned earlier, you're trying to study the epidurals in pediatric anesthesia. You want to see whether what is the exact dosage you want to administer. So that may be the specific problem you want to address in your research question or your research project. So it can point to an existing uncertainty in the area. For example, does institution of ECMO reduce the mortality in patients with severe ARDS? As you know, ARDS is a problem which is occurring commonly with COVID-19. And now there are a lot of studies which have examined the utilization of ECMO. So now that may be an existing uncertainty for you, because many of the studies may be ambivalent, and so you may try to answer that question. So you are interested in a new concept of ECMO, the lacunae, where it actually lacunae is where you want to see whether it actually reduces the mortality. Now, it need not be an exact lacunae as such. It may also be that there is some ambivalence among the study results. That is, some studies may say there is some improvement in the mortality, or some studies may say there is no improvement in the mortality. These study designs may be different. They may be of an observational study. You may want to improve on the study design. So there are a lot of concepts involved, and that improves your novelty of your study or your research concept. So this also guides you on to form a hypothesis. So a hypothesis can be null or alternate. We'll go into the details of that later. There's a second part of our query today. And you formulate a methodology to study if ECMO actually reduces mortality in patients with severe ARDS or not. So based on the available infrastructure in your institute or in your this one, you try to, in your institute or place of work, you try to formulate a research methodology which would be appropriate and try to explain this question accordingly and with which surpasses the validity and can be replicated in the general population. This is what you actually try to do. So, and a literature search that you actually do before you start your study, or your review of literature in your thesis that you actually write, is actually formulated on the research question and based on the keywords that are obtained from your research question. So a research question is actually a paragraph. It need not be a single sentence, as I have mentioned in the previous slide. It can be a paragraph. It can so based on that paragraph, you obtain certain keywords which may give you optimum results while trying to do a literature search. This yields better results and it's easier to control the literature search. So actually, I think somebody will be dealing with the part of literature search, or it's already been dealt earlier. So it's very easy to control the literature search if you have the appropriate keywords. A vague research question may yield a vague literature on search, and it may not be very useful for you. You may not learn anything new. So it's important to formulate a research question which is optimum and probably best answers tries to answer your question best. So what is the source of your research question? So there can be various sources for your research question. It can be previous research, journals, scientific events, discussions with other colleagues. It can be anything. It can be new ideas or technologies or untested theories. It can just be a new idea. It need not be something from a previous research. Or it can be from practical experience. So everyday practice, you notice something that you want to answer, can be formulated into a research question, and you try to answer that in your research methodology. Or it can be teaching. Somebody teaches you something, you find some lacunae in that, or you find some query that arises in your mind, and you try to answer that research question. And or there can be some variability in clinical practice. You may observe that one of your colleagues may be doing something in a different way, and you want to know whether your practice is better or your colleague's practice is better, and you want to validate your practice. So it can be a variability in clinical practice that you want to see which is better, and you want to improve your own practice. So what is the basis for a research question? So your questions can be based on either interventions that you want to study. There can be different interventions. Like for example, you may want to compare combined spinal epidural analgesia versus continuous epidural analgesia for labor pains. Or it can be a treatment or a therapy. It can be, say for example, for COVID, you want to compare favipiravir with remdesivir, or you can just compare add remdesivir without remdesivir. Or it can be a prognosis or a prediction. You may want to prognosticate based on certain scoring systems or based on certain parameters that you have found in your clinical practice. Or it can be a diagnostic study. Sometimes you may want to diagnose actually what you want to do. And it can be to identify an etiology or the cause of a disease, or it can be the cause of a complication also. So as I said earlier, I have some examples here. It can be existential. Say for example, can neonates perceive pain? So it can be an existential research question. Or it can be a description and classification kind of a research question. What are the characteristics and types of ARDS? So this can be a research question. Compositions, it can be what are the stages of COVID-19 ARDS. Here we're trying to find out what is the composition of the syndrome ARDS which occurs due to COVID-19. And it can be a relationship question also. Association of COVID-19 infection and strokes. So you're trying to find the relationship between strokes and COVID-19 infection. And it can be descriptive, comparative. Are males more susceptible to COVID-19 infection than females? So you're trying to describe what is the syndrome, how the syndrome occurs, and how some certain subset of patients are more susceptible to COVID-19. It can imply, the research question can imply causality. Does infection with SARS-CoV-19, SARS-CoV-2 lead to ARDS? So it can, does it actually cause ARDS or something else causes it? Or causality comparative, does ECMO improve survival in patients with ARDS compared to mechanical ventilation? Or it can be causality with comparative interactions, does remdesivir improve outcomes in patients with severe COVID-19 infection? So these can be the various types of research questions. And what are the components of a good research question? So once you frame a good research question, you try to frame it in such a way that the research question will stand and will be accepted by any other researcher of good standing. So you try to detail the problem statement. It should contain all the details of the problem statement or the point you want to research on. It should refine the issue. It should try to bring in clarity to the issue. It should add a focus to a certain point which you actually want to study, or it has to guide the methodology. So later you may want to frame a research question in such a way, it has to be framed in such a way that it guides the methodology and it sets the context for your research. So it sets the tone for your hypothesis, which is developed later. It sets the tone for your analysis. It sets the tone for your methodology also. So usually research questions are usually single primary research question, and additional questions can always be considered as secondary questions. They are not, you don't concentrate much on them. Even though you do investigate them, you find out the variables for them, and you do try to find out the answers for these secondary questions. Or there is always a single primary question which should try to answer your research idea. So going on to the next part, which is framing a research question. So how do you actually frame a research question? What is advocated is a systematic method for raising a research question, and it's called as PICO approach. It can either be PICO approach or T is added sometimes. And this is the evidence-based model for framing the research question. We'll go into the details of each part of the PICO approach. So these are the elements that are there in a good research question. The PICO approach requires that the research question contains the target population, the intervention of interest, the comparator intervention, the key outcomes, and the time frame over which the outcomes are assessed. So it can be the time frame during which the outcomes are assessed, or it can even be the time frame over which the outcomes are assessed. So let us see how we obtain a good, if we have a good research question, how we obtain the actual keywords that are important to us. So let us say, for example, there is a question saying, does urban air population increase mortality in a population? The search query is formulated by patient, intervention, comparison, and outcome. And in that, the main population that is studied is the urban population. So you can use keywords such as city population, inner city population. So you go into MESH website and you try to search appropriate keywords, you'll find urban population. And for intervention, which is air pollution. So air pollution is a thing that is the intervening factor. And you look at the layman terms, which are poor air quality or polluted air. And then you try to find the mesh words which are suitable for that, which are air pollution or air pollutants, etc. So these can be the alternative keywords. So you make a combination of such keywords and try to go through the literature that you obtain by the literature search. So what is the exact PICO format that you actually look for? So population means population P, or population means it refers to the sample of subjects you want to recruit. So there is a population, the population means the sample of subjects you want to recruit for your study. So it refers to that. It is actually not the exact population as such. You want to take a sample from that population and you want to do your study from that. So this sample should represent the original population of which you want to generalize the study for. So I is for intervention. So you try to do some specific tests, therapies, you have some medications which you want to study, or habits or patient health status. So depending on this, all these can be interventions. So it is denoted by the term A. So C is comparator or comparison. Identifies what you plan on using as a reference for the group. You want to compare it with some group. Say, for example, you have taken a sample population, you have introduced an intervention for that sample population, and there is going to be either there is going to be some intervention that you want to compare it with, or there's going to be no intervention that you want to compare with. So that intervention, the group which you don't do an intervention or have a standard intervention is called as the control group. And if the existing treatment is considered as a gold standard, that can be your control group actually. So standard therapy in your institute can also be the control group. It did not be exactly the placebo group. In fact, nowadays placebo studies are not done. Most of them frowned on placebo studies. They consider standard therapy as the control group. So O stands for outcomes. So outcomes represent what result you plan on measuring and pressuring for determining the effectiveness of your intervention. So let us say you want to measure pain in a patient. So usually the outcome that you measure is the VAS score or the NRS score. Commonly what they measure nowadays is the NRS score. So this may be the outcome measure. So actually you're trying to denote your pain in terms of a measurable outcome. So there can be familiar and validated outcome measurement tools. It's very important to use these validated outcome measurement tools. If you create your own tool, then it's always better to validate it prior to using it in your study. So time describes the period of the study, the time period at which the study occurs. It can be in the perioperative period, it can be post-operatively for the past for 1 hour, or it can be of the duration of the data collection also sometimes. So it can be for 1 year, 2 years. It may depend on a lot of things. So why use the PICOT technique? Why do you think it's important to use the PICOT technique? So the PICOT technique is an evidence-based model. It enhances the clarity of the thought process in developing the research protocol, and it gives it also informs about the design of the study that you have to employ. It guides the analysis, and a good research question developed based on PICOT technique ensures your publication. That means that the a person of a good standing, a researcher of good standing who assesses your article for publication will be able to understand what you're trying to report, associated with overall quality of reporting. So a good research question again bears on the quality of reporting. So these are some templates that I have, say for example, intervention. So in diabetics, how does metformin compared to vildagliptin affect the acid-base status within the perioperative period, let us say. So that can be an interventional study. So similar templates are there for asking PICO questions with respect to therapy, prognosis, diagnosis, etiology, and meaning. So these are all the examples again. So what are the essential requirements that are required of a good research question? So turning a good idea into a good research question requires that it meets the FINER criteria. Again, this is an acronym. And a good research question should be appropriate, meaningful, and purposeful. This is what is very, very important. And this meaningfulness, appropriateness, and purposefulness is assessed by a FINER criteria. So what is this FINER criteria? So in FINER criteria, F stands for the word feasible. Is the research, you have to assess whether the research question is feasible. All this is done once the research question has already been framed. And once it is done, you try to see whether it is actually feasible in your institute. You should be able to get adequate number of subjects or the sample size. You should be able to meet the sample size. You should have adequate technical expertise. You should have, it should be affordable in terms of time and money, and it should be manageable in terms of scope. Okay, so how do you modify your research question if by chance there is some deficit in one of these factors which you assess for feasibility. So what you can do is you can try to do a pilot study. You can see whether it can be feasible. Then you can modify the inclusion and the exclusion criteria if necessary. If you're not able to meet the sample size, and the inclusion and exclusion criteria can be modified in such a way that there is not much of bias, or um, there's not much of bias in the study, then you can do that. You can get collaborators. You can try to do a multi-center trial. You can try to involve more people. You can learn the technique. Say, for example, you don't have the technical expertise to do ultrasound guided sciatic nerve block. You can learn about ultrasound guided sciatic nerve block and then go ahead with the study. And you can consult experts on how to modify your research question in such a way that it will be feasible in your institute. And you can try to get sufficient resources in terms of experienced staff and funding. So it's very important to get the right amount of resources. You alone cannot do a study. It is going to be very, very difficult. So you should have a good team and try to find proper funding so that you both can help you in making your research question feasible. Do you find your research question interesting? So it should be interesting to the researcher, it should be interesting to the collaborators, it should be interesting to all the stakeholders, including the patients. If it's not interesting to the patient, he may not agree to participate in the study. So how do you make your research question more interesting? You consult your mentors, you consult your peers, you try to modify your research question in such a way that it looks more interesting to all of us. And is it novel? So it should either very rarely nowadays, it should either confirm a previous finding. Say, for example, some particular study has been done in the United States of America. You want to confirm whether the same findings can be found in India. You can go ahead and do that. Or it can refute the previous findings. Let us say, for example, they have done a study on gastric aspiration and residual gastric volume in patients who have undergone surgery using a RIDES tube. You want to do it with a gastroscope, which may refute the previous findings. That's a good thing. Or extends your findings from previous research, or it may add more value. Let us say, for example, somebody has done a study only on residual gastric volume. You want to assess the gastric pH also, which is also important to you in your research question. So you can do that. That research question will again be novel. So how do you make your research question novel? Consult a mentor, consult your peers, try to take their advice. So is it ethical? So you have to go back once you frame the research question and examine whether it is likely to be approved by your institutional ethical committee. So it's very important to see that, and you have to be familiar with all the research ethical guidelines, the Declaration of Helsinki, the Institutional Review Board guidelines, and you have to have some knowledge about Clinical Trial Registry of India. So you have to go through all these guidelines and be familiar with them. The next question that you have to ask is your research question actually relevant? So is it relevant with respect to current scientific knowledge and policy, or is it relevant, or does it give some future direction to research? So you have to go through your research question and see whether these parameters are met. And if they don't meet that, you need to get good guidance from experienced researchers or mentors and your peers. So what are the common problems you may face while framing a research question? It can be too broad sometimes. If it's too broad, you can go ahead and try to reduce the number of variables you're studying or narrow down the question. It may not enough subjects. You may not be able to get enough subjects in the time frame that you're given for the research. You can modify the inclusion and exclusion criteria, as I mentioned earlier. Or sometimes it can be beyond the skill of the investigator with respect to the technique. So expand your skills. It can be too expensive. That may be one factor which is very, very important, and you have to go through in detail. Or it may not be very interesting or relevant. So you need to consult your peers and modify your research question. So these are the common steps that are followed while framing the research question. So step one is identify the research problem or idea. And step two, consider options for PICO element for framing the research question. So here on the right-hand side is the population intervention control, what you have to look at, outcome and time frame. and there is a research question that has actually been framed. We'll see one example later. And focus the research question. You narrow down the research question in such a way that it looks more interesting, and you check whether the question follows the finer criteria. So you follow these 4 steps. It's going to be very, very important to follow these 4 steps so that you frame a proper research question. And this is said to be the roadmap for determining and framing the researchable questions. So as I said earlier, step 1 is identify the problem or the idea. Step 2 is consider PICO options for framing research questions. And 3, prepare a focused research question based on these factors and check whether the research question meets the final criteria. So let's see one small example. In adults undergoing elective surgery, there's treatment with epidural analgesia in combination with acetaminophen, that is multimodal analgesia, compared with epidural alone, single modal, lead to better pain relief and less side effects. In in the following surgery. That is. So let us see the population. The population is the adult patients undergoing elective surgery, and I is treatment for epidural analgesia in combination with acetaminophen and other NSAIDs. And the comparator or the compared control group is the epidural alone. Outcome is better pain relief and less side effects, and T is over 24 hours following the surgery. So that is the duration of the time frame over which you're going to study the patient. So is it feasible? Yes, you can do. You'll be able to get a good sample size. Most of the institutes will have that. Is it interesting? Yes, definitely it's interesting. Is it a novel idea? Yes, it's a novel idea. Is it ethical? Yes, it would be. Pain relief is a big part of anesthesia, and it would be really ethical to go ahead with that. Instead, if we had chosen a placebo group here to compare, then it would not have been ethical. So here it is definitely ethical. And is it relevant with current concepts or current research? Definitely it is relevant. So this would form a good research question. So once we have gone on with the research question, the next step in formulating a research protocol is forming your research hypothesis. So what is a research hypothesis? So research hypothesis is a statement that suggests a relationship between two or more variables that answer the research question. So based on the research question, you're trying to come out with a hypothesis you're trying to bring a relationship which specifies the relationship between two variables or more variables and answer the research question. So compared to a research hypothesis, a research question, your research hypothesis is a more declarative statement. It explains or predicts the relationship between two outcome variables. So we'll go on to more examples of that. We'll try to calculate and try to test the hypothesis also later on. So what are the characteristics of a good hypothesis? So let us say the main characteristics of a good hypothesis is the relationship statement. It has to be a declarative statement, and the nature of the relationship between variables associated or the causal variables is mentioned. So a good hypothesis mentions both. And a good hypothesis should be testable. You should be able to observe the variables, you should be able to measure the variables, and you should be able to conduct analysis of the variables. So let us say, for example, as I mentioned earlier, pain. If you want to measure pain, there are various scores that are available. You cannot just say that the pain by itself is not a measurable quantity. So you can definitely observe pain. So let us say, for example, you take the variable NRS score. So NRS score you can observe, you can measure, and you can definitely analyze the variables when you go and do a analysis. It should have a good theoretical base. So a strong theoretical base should be consistent with current research and should be based on sound scientific principles, which are derived either from previous research or from clinical observation. It can be any of these. Only thing is, your hypothesis has to be based on theory. Let us go on later when we talk about the examples. We'll talk about whether they are based on good theory or not, sound theory or not. So in short, a good hypothesis is concise, clear, simple, denoting the variables, the population that is studied, and the likely outcome that may occur. So you're just hypothesizing or imagining or guessing what can be the relationship between two outcomes. So there are various kinds of hypotheses. It can be research hypothesis, it can be statistical hypothesis. So a research hypothesis is nothing but a statement showing the relationship between the variables. A statistical hypothesis is, however, usually one that assumes that there is no relationship between the variables. So usually, commonly, a statistical hypothesis is something which is called as a null hypothesis. There's something called as a alternate hypothesis also. This alternate hypothesis assumes that there is some relationship between the variables.
Dr. Pradeep, sorry to bother you in between. We are running short of time, so your time is over.
Okay,
if
sir.
you can wind up fast, it will be great.
I'll finish in 2 minutes.
Thank you very much, sir.
Yeah, sure. So there are two types. One can be directional. So if there is a specific direction to your hypothesis, it can be non-directional. So if the null hypothesis, what we actually mean is, if it is non-directional, we say that, say for example, you're examining two means, you say that mean 1 is equal to mean 2, or mean 1 minus mean 2 is equal to 0. If it's directional, it can be either mean 1 less than mean 2, or it can be mean 1 greater than mean 2. Alternate hypothesis can also be directional or non-directional. So of course, here you examine that one mean is greater than the other or lesser than the other. And if it's non-directional, you say mean 1 minus mean 2 is not equal to 0. You don't give a specific direction to it. You don't say whether it's greater or lesser. So directional hypothesis, of course, is based on an informed hunch, and it indicates a sound theoretical base, whereas non-directional hypothesis is impartial or more objective. And coming to hypothesis testing, of course, what you're trying to do in a hypothesis testing is you're trying to find out if the probability of the test sample, the mean or whatever, the variable that is there, the combined value of the variable in terms of mean, median, or whatever, whether it falls within the nearer to the population variable. So usually done with a 2x2 table. So let's go to one example. Let us say that hypothesis is that continuous epidural infusion is as effective as intermittent doses of analgesia for any patient coming for post-surgically. So you collect the data, you find that the satisfaction scores for the patients in the intermittent bolus dose was 7.23 plus or minus 0.2. For the other group, it is 9.26. So here you try to estimate that what is the probability that the result is by chance. So when you say that you're testing a hypothesis, you're trying to estimate that there is some difference in the mean value that is obtained for the sample group or the intervention group. You're trying to find out what is the probability that this result is actually by chance, and hence prove a null hypothesis. So it is usually based on your central limit theorem. So this is actually the 2x2 table. I don't want to go into the details of that. You just need to know about type 1 error and the type 2 error. Type 1 occurs when the error occurs when the null hypothesis is wrongly rejected, actually. So actually the sample has there is a difference in the study population, but the null hypothesis is wrongly rejected. Okay. The type 2 error is when the null hypothesis is not rejected, even though actually it is false. So the null hypothesis is actually false, but it is not rejected. So that is when the type 2 error occurs. And you're trying to limit the type 1 error whenever you do the study. To reject a null hypothesis, we need to know a few things. We need to know the variables that have been studied, the number of groups that are there, and whether the groups are independent of each other. So you assume your type 1 error, that is your alpha error, to be 0.05. That means that there's a 5% chance. Any chance greater than, there's only a chance of up to 5% that the null hypothesis will be proved wrong. So let us see, I've gone through the formulas. I don't think I have the time for each. Let us say, taking the above example, this is the normal curve that I have obtained. And you see the shaded area there, the pink shaded area. So you see that I have calculated the t-score, which is around 5.26. And the acceptable t-score is 1.645, which corresponds to your alpha error of 0.05. you see that 5.26 is far beyond the beyond 1.64. That means to say that probably there is a significant difference between the two groups, means of the two groups. So there is not much of chance that, so you can reject your null hypothesis. So your hypothesis, your problem statement, your theoretical framework, and your literature review are all interrelated. And you get an initial, how do you go ahead with the research project? You get an initial idea, you or from your clinical observations or from research, you review the literature, you frame the research question, you frame the operational constructs, and then you frame the research hypothesis, and then you go ahead with it. So this is comparing the research model, the common language, and when you publish the article, where what comes. And my take-home message would be formulation of a research question and stating a good hypothesis, a preliminary step to research. Follow the PICO and evaluate using finer for a research question. Base both research question and hypothesis on sound literature, and a good research hypothesis has to be based on sound knowledge and testability and must have a relationship statement. Thank you.
Thank you, Dr. Pradeep. That was really a very interesting, a very nice presentation on a topic that's extremely important. And I think we all agree that a well-considered, strong research question is the most fundamental aspect of any research. As Dr. Jayashree ma'am was saying today, a lot of students are also listening in to our webinar today. And I'm sure many of us must have faced this problem that a student comes to us and, the research question is something like this: the effect of nalbuphine in addition to bupivacaine on the sensory block characteristics, postoperative analgesia, hemodynamics, and postoperative complications. So, this is the kind of a research statement that most of our students come up with. And there is a lot of confusion as to what is the relation of a research statement to the primary objective or the primary outcome. So if you would like to, shed some light on that, your comments on that, I think we need to, clarify that for our students who are listening in to us. Too many parameters in a research statement.
Ma'am, I didn't get you.
Many a times a research question has many variables.
Yeah.
Is that a good research statement?
No, ma'am.
How specific should it be? Is our primary objective or our primary outcome the research statement?
Exactly.
If you can shed some light on that, because this is what we face all the time. The residents are extremely, they want to put in 8 things in one research statement. So I'm putting this across so that we have absolute clarity from the expert regarding the research question.
Yeah, the research question is usually a broader statement compared to the hypothesis, ma'am, and the abstract and the construction of variables. You try to limit the number of variables that you're actually going to study. That's there, and it's important to have a primary research question and a primary variable that you're going to study. As much as possible, concentrate on one area of the aspect that you want to study, rather than have a broad research question that's going to lead you nowhere. It's going to confuse you more. There's going to be more variables. And also whenever you examine a variable in terms of statistics, the variable that you use for your sample size carries the best value, because that is the one that is the results on that one is going to be well powered. Your secondary variables may not be that well powered. You really don't know. So it's always better that you have one research question, simple, narrow as possible. You should not make it too narrow also. Narrow research question. That's better. The rest of the things can be secondary parameters. They need not be the primary ones.
So it's very important to have a very specific research question. There should be no ambiguity on it, and minimal, and preferably your primary outcome or the primary objective of your study. Yes, that's an extremely important point that I wanted to bring across. The other very important point that I think our residents and our students must be very clear about is the ethics of the research question. So while clinical trial registry notification is a very good idea, however, I think it's more of a registration body than an ethical consideration body. Nowadays, in fact, it is a good idea to go for a DCGI notification when you are planning a research. In case of a clinical trial, I think it's extremely important that you should go for permission from your DCGI. In an academic trial, as per the 2018 Gazette notification, just notifying the DCGI is good enough, especially when we are repurposing any drug. So that was one thing that I just wanted to add in for the benefit of our residents.
I agree with you, ma'am. Actually, some of these things are given in the CTRI. So that's why I put that point there, that it's important to read the guidelines, because before you register your trial, these criteria have to be met. So certain criteria have to be met.
Yes, yes. So very often the students don't know that even DCGI notification is important. So just wanted to bring this point across for the benefit of our participants today. Thank you once again, Dr. Pradeep. Dr. Govind, sir, would you like to?
No, ma'am. Thank you very much. You have covered excellently everything, and Dr. Pradeep has covered everything excellently. Thank you.
That was really a very excellent presentation.
Yeah. Thank you very much.
Thank you so much.
Is it all right, Dr. Rakesh, if we can ask a question?
Yeah, please go ahead, ma'am.
Right. So, Dr. Pradeep, actually, it's more of an anecdotal question. Why is it that we always test null hypothesis and never an alternative hypothesis? I mean, why is this background of statistical research where I need to prove that the null is valid or invalid? Any comments on that for our students?
Ma'am, actually, it's actually a standard question, standard thing that is done, practice that is done, that you have a null hypothesis and you try to disprove the null hypothesis.
Yes.
So there are two things here. There are two things here. One thing is basically you have to see whether your null hypothesis can have a direction also. It need not mean that there is actually no change. So sometimes there can be a change, there can be a one directional change, and your alternate hypothesis may have something like the opposite effect. That can happen. So what you design as the null hypothesis, you try to disprove. That's what I have learned from this one.
So
that is
actually,
one thing.
in here, I could probably offer a comment, because I happened to read this somewhere and I found it so true. Why did the concept of null hypothesis come around? We could have based our entire scientific research by saying that there is a significant difference, and then between, let's say, A and B interventions, and then we could have tried to prove or disprove it. However, we always start by saying that there is no difference, that's the null, and then I try and prove or disprove it depending on the p-value which we have chosen arbitrarily. It goes something like this. Human beings are cynics and cynical by nature. We find it hard to believe anything. So if I was to tell you that all cats in the world are black, you will say, no, I don't believe this. If I tell you that all cats in the world are not black, you'll say, yeah, that's true. But could you just prove it? So that is all a null hypothesis is. Then let's start out by saying that there is no difference, because then probably it will be more receptive to a human mind. So that was just to share. Thank you.
So thank you so much. Any comments from Dr. Bharti and Dr. Deepak? Any contributing comments from your side?
No, Dr. Tyagi has explained very well. And the example she gave is very interesting and very good.
Yeah.
Thank you very much.
My pleasure. My pleasure.
Thank you so much, eminent chairperson, Dr. Bharti ma'am and Dr. Deepak Govil for taking this session. For the next session, we have another two eminent chairperson, Dr. Pradeep Bhatia, who is professor and head Department of Anaesthesiology, Critical Care, AIMS, Jodhpur. He is editor-in-chief of Journal of Anaesthesiology and Clinical Pharmacology. He is also editor-in-chief for the Indian Anesthetist Forum. He has many academic, clinical, and research accolades to him, and he's a very well-known personality in anesthesia and critical care, not only nationally, but across internationally also. Welcome, sir. The another chairperson is Professor Hamad Usmani, who is professor at Department of Anaesthesiology, Pain and Critical Care at Aligarh University. He is also editor-in-chief for the Indian Journal of Pain, and he has a very good number of papers and research, and he is a wonderful academician leading the Indian Journal of Pain in a very, very positive direction. Welcome, Dr. Osmani, and over to you.
Thank you, sir, for the kind words. I'm looking for my colleague. Where is Dr. Bhatia?
Yeah, I'm here only. Yeah.
Acha, great, sir. Great, that's great.
So, good evening, everyone. So, it's a pleasure to be a part of this webinar conducted by Indian College of Anaesthesiologists on essentials of research and publications. So, I would like to invite the next speaker, Dr. Rakesh Garg himself, who introduced me to chair the session. And it's a pleasure to invite Dr. Rakesh. And he's a well-known, young, energetic, enthusiastic anesthesiologist who is there in almost all the conferences, who is there in almost all the journal publications, integral part of most of the important journals. He's working as associate professor at IRCH AIIMS Delhi. And his interests are onco-anesthesia, pain palliative care, and he has more than 200 publications to his credit. And he'll be speaking on study planning and methodology of research. Dr.
Thank you,
Rakesh,
sir.
please.
Thank you, sir, for the kind words. So in continuation to the previous session, so once we have cleared about the hypothesis and research question, it's the time to plan it, that how it needs to be translated into a doable form. I bring greetings from my institute. So we have already talked in the last session that the research process is a well-known process, and every step is equally important if you want to have a concrete outcome which is repeatable and dependable, and that needs to be followed. The previous session and even in the last webinar, we did talk about the aims, objective, research, and hypothesis. So once we understood it, the research hypothesis, or you can say the research question, needs to be translated into a doable format, and that is what the methodology is. It provides a detailed strategy that how these objectives should be achieved. And they should be in such a detail that it is absolutely replicable, and each aspect is detailed to the extent that anybody who is doing it can do it in exactly the same form. The components of methods section are many, so I'll just take you one by one. First and most important is you need to disclose that what would be the appropriate study design to answer the research question that you have developed. In the last webinar of the Indian College of Anaesthesiologists, we have discussed about various study design, and we did talk about that which are the various research questions and what are the appropriate study designs that can be answered through that. So it is very, very essential to have a concrete research question based on PICOT, and then you need to select the study design accordingly based on the review of literature that would be able to answer your research question appropriately. The method section should also emphasize upon the study period that you will be doing it, because sometimes it happens that the protocol or the intervention that you're doing is they may change with time. So one should be very clear that this recruitment of patients has been done in this duration, and that's why you should be disclosing the study period. And similarly, the study area, that which are the locations you are doing a study, will also be mentioned. One is about whether it is hospital-based or community-based. And even if we are disclosing the hospital, if somebody is working at a tertiary care center vis-a-vis a district hospital and doing a research, it becomes important to understand, because the population which are coming here will be selectively different in a tertiary care referral center vis-a-vis district hospital. So maybe that outcome that we are looking for may be a little different, because the patient profile would be a little different. And that becomes very, very essential to disclose that which will be the study area. The study subjects and participants, again, it becomes very important that they are able to answer your queries appropriately without having much confusion about the various bias or confounder, which will I come a little later regarding the patient's inclusion or selection into the patient. Remember, this is a usual mistake that we do, that we try to exclude those patients which we have not included. So the exclusion is only from those patients which has been a part of your study. So be very careful about these parameters, and also try to include whether how much or what will be the parameters wherein you will discontinue your intervention or you will discontinue the follow-up of patients. So that should be very, very clear in detailed manner, and probably more objectively, so that they become replicable. The data collection, compilation, data entry, cleaning, and analysis plan must be disclosed into your method section very, very clearly and elaborately, because these are important aspects. Because if you're not disclosing them, if you're not mentioning them into detail, it may give an impression that there would be some bias into these collections of data as well. Also, whatever the study tools terminologies you are using, they should be defined clearly in proper definition form. For example, if you say that the pain will be measured in a patient if you are doing some intervention for adjuvants in various regional blocks, then you should mention that the pain will be assessed using numerical rating scale at this duration. So this should be specified in your method section so that the variability of the existence of various tools may give you different values, and hence it should be very, very clear that which tools are you going to use. And similarly, you can have your performance measurement tools and everything in very, very clear. The other example I would make it clarified here. For example, if you want to say that the blood pressure will be monitored, it should be clear that what type of blood pressure monitoring you are going to do, whether it's invasive versus non-invasive. Even in non-invasive, whether you are using automated type of blood pressure monitoring or you are using manual type of blood pressure monitoring. Manual could be mercury, though it is banned now, or it's an aneroid base. So this means whatever tool that you are using for collecting the data should be clarified into the method section. And if you're using any test or any questionnaires, they are again should be standardized or they should be validated. Validated means that somebody has done a validation, published, and found that they have been appropriate. In the language that we are using, it also becomes essential. So you should use the instrument or tools which are standardized, which are validated in your study. If they are not, then you should try to make some validation before you start using them, because it is very, very essential to use a validated tool for confirming some outcome based on your research question. Also, it is very important to mention that whatever observation you are taking, whether it's blood pressure, it is pain monitoring, how, when, and where these observations are being made, they should be clarified here. Whatever the clinical examination findings you are doing it, if you are using, say, looking for the hepatic enlargement, whether you are doing it clinically or using ultrasonography, you should mention here. Similarly, for laboratory tests, for example, if you're looking for the stress response in a critical care setup and you want to monitor the blood glucose level, be very clear whether you are using the blood glucose levels from the arterial blood sampling using an ABG analysis, or you are using a plasma sample, or you are using a capillary sample using a glucometer, because each will give you a different blood glucose levels. So that's why the test that you are using should be very, very clear. Any interventions or any blocks should also be clarified, because there could be many options or many techniques of putting up a block or doing an intervention. So all intervention, you should clarify that you will be using this technique if it is related to your objective. The questionnaire, as I mentioned, should be validated or standardized. And if it is a qualitative type of study where you are interviewing the patient, try to make it more objective, more structured, so that you are very, very careful that similar type of interview is being done across your selected population. Ensure the confidentiality. That's why when you prepare a case record form, you should always try to make some marker so that the exact patient's data is not coming on them, and you can give them some numbers or something so that their confidentiality is maintained. Also ensure that appropriate approvals are taken from ethical committee or institutional review board or animal committee in case if it involves animal, and other approvals regarding the DGCI or from the radiological exposure if you're taking, then you have to take those approvals from appropriate authority before you start doing that. The other important aspect is to understand the variables that you're using. It is very, very important that what type of variables we are using, because sometimes when we try to answer a research question, we'll be putting them into a qualitative or a quantitative variable. For example, we want to look for whether the patient was hypertensive or normotensive, and we just put up a case record form and tick it. Now, this is a qualitative data. But suppose after the study, we want to know that those patients who were hypertensive, whether they were having BP of around 140 to 60 or more than 160, then we will not be having this data because we have collected the qualitative variable into our case record form. So it should be very clear that what type of data we are collecting and how will it be used for analysis. So you should be ensuring the correct choice of variables when you start doing your study. The other important aspect is about the sampling, randomization, allocation, concealment, priming, and masking. And these are the very important aspects, because if you don't do them appropriately, it guarantees that your paper will not have good outcome or reliable outcome, and it will not be published in any of the journals. Now, why do we do sampling? The reason is we cannot study the whole universe. That would have been the best. But we want to sample a group from a larger population and try to extrapolate the outcome of this sample to the whole population. And this is to give a chance to all the patients that should have non-zero probability. And that is what the sampling is. We can do a sampling, probability sampling, which is the gold standard. But sometimes we have to do a non-probability sampling, which could be convenience, snowballing, or a purposive sampling. These sampling are not the gold standard. They have their own issues, but they can be done where the random samples are not possible. For example, a rare disease. For example, if you want to look for the airway management in Treacher-Collins syndrome, or a metabolic abnormality in some of the disease. So you will not be getting a good number of patients. You cannot randomize them. So these are the things: a rare disease, small population, special condition, difficult to reach population, where you can use non-probability samples, but probability samples remains the scientific basis based on which your all analysis and interpretations are there. And the general ability is much, much better to choose from the probability samples. These are the various options that we use for probability sampling: simple random, systematic random, stratified random, and cluster sample. And this is the selection of randomization will depend upon what type of research question you have framed. So once we have sampled the population, a target population and a study population, and then a study population sample from this, we randomize this into respective groups. Now this can be, when we say about the experimental research, this could be a single group design or a control group design. Now, when we say a single group design, you just do an intervention, all receive some intervention, and then you compare pre with post of whatever parameters of your choice. In a control group, you do interventions in one and do not do the intervention other, or you do some standard of care and then try to compare that what change has been seen in a population in which the desired intervention has been done. Now, why do we need a control group? The reason is, if you see the patient profile, there's something called a placebo effect. For example, if you are looking for the pain management, and if you go in the postoperative ward and try to assess for the numerical rating scale, maybe your presence, because you are seeing the patient, you are providing care to the patient, even your presence may alleviate the pain, and this is well known. So this means this placebo effect needs to be balanced in both the groups, and that's why we require a control so that the placebo effect is comparable in the two groups, and hence we can compare the real outcome of the intervention that we are doing. Sometimes the placebo may not be possible or ethical. For example, you cannot, if you want to look for the effect of fentanyl on the hemodynamic response during the airway management. So this does not mean that we'll not give fentanyl to one group. It is unethical. So we can do a low dose group. You can give 1 mg in one group and 2 mg in one group, and then try to compare them, or use the standard current therapy or the gold standard. So this is what we need to do for a control group rather than just placebo in case it is not ethical. The other aspect is the randomization, and this enables a fair and unbiased comparison of study intervention, because we want that there would be some known and unknown factors which would be there in the whole population, and we want to balance them. The known factors means if you want to know the hypertension, diabetes, we can know it, but there could be unknown factors for maybe the patient has inherent anxiety, which we cannot assess as such. So we want to have those equal distribution, and hence it becomes essential to randomize them. The methods are many, manual methods or using computerized methods. The manual methods, most of them using like date of birth or day of presentation. These methods should not be used because they can create bias. Most of the time, either we are using these type of manual methods using the random number table, or nowadays we are using more of a computerized random number generation that will give us a randomization sequence. But sometimes we do require stratified randomization. If, for example, say some feature is being affected, and if they are different in two groups, then the outcome may be affected. For example, if you are looking for some outcome parameter, and that can be affected by age, even between 18 to 60 years, we can stratify them between 18 to 45 years and 45 to 60 years, and each stratified group can then be randomized so that both the groups has equal number of population between 18 to 45 and 45 to 60, and this is what is called as stratified randomization. Once you have done randomization, but if you know the sequence, again, it can lead to selection bias. So we need to conceal the randomized sequence, and this is what is called as allocation concealment. Now, allocation concealment, it sees the knowledge of forthcoming assignment of a researcher of a recruited population. And this becomes essential because if you know the next patient is going to be in this group, maybe you may not recruit it. So that's why the concealment is required so that the selection bias does not happen. The various methods are being used. It could be telephone-based or sequential number containers or pharmacy controlled or central randomization. The most commonly used is sequentially numbered opaque sealed envelope, which is also called a snooze technique. The blinding and masking is again very important because it is important because if we know that what intervention has been done in which patient, we may be a little biased in assessing the outcomes. That's why blinding should be done in all the study groups. Earlier, we need to mention them as single blind, double blind, triple blind, but nowadays we do not use this terminology. What we do is blind as many as individuals who are involved into that particular research. Participants, practitioners, data collectors, outcome adjudicators, data analysts, statistician people, anybody, if you want, who are involved into research should be blinded for the intervention that you have done. In case if blinding is not possible, for example, the intubation technique using video laryngoscope versus fiber optic, so you will not be able to blind it. In those situations, try to make the objective or the outcome parameter more objective so that the errors are less. You can record them and then measure the time duration. Or you can use an independent outcome assessor who is not involved into your study. If blinding is not possible, standardize the treatment, use objective parameters, duplicate assessment, and it becomes a limitation of your study. Now, having said that, whatever we do, there could be bias and confounders, which can start from exposure to outcome, and that also needs to be taken care of. Now, difference between bias and confounder is, bias is the systematic tendency of any aspect of the study conduct, which could be design, conduct, analysis, and interpretation. So this is an inherent internal issues with this study. While the confounder is an extraneous related, which is related to your exposure and the outcome. So this is what needs to be understood. The bias can be or bias can be at any aspect from patient or the person who are collecting in the form of selection bias, recall bias, observer bias, measurement bias. So it should be, that's why we mentioned in the method section, you should be very clearly mentioning that what type of measurement tools, timings, and equipments you are using should be mentioned. Now, when we say confounder, if we say a disease is caused by a particular parameter, but there could be some other factors that can affect both. For example, coffee consumption can lead to pancreatic cancer, but smoking has been seen more in patients or persons who have coffee, and they also cause pancreatic cancer. So smoking is a confounder here. We need to identify when we create a research question and becomes important. The other aspect of your method section that you should disclose that what type of statistical tools you will be using for the analysis. Now, these are the reporting guidelines. Based on the study design, you can use them. And these are primarily based on this algorithm. You can go to the website of www.equator.com, wherein you can see that which type of reporting format needs to be used, and it will show the whole components. Though they are reporting components, but they should be part of your method section so that it becomes incomplete when you are reporting them for publication also. So to summarize, a well-planned and a well-designed study requires a robust method section, a detailed method section. And if you see the recent publications and compare them with publications which were published 30 years back, 30 years back, there used to be a half a page of method section, a 3 pages of a discussion section. But if you see the today's study, it will be 2 to 3 pages of method section and maybe a half or 1 page of discussion section, because we are more concerned that whatever outcome that you are showing to us or discussing to us, they should be done in a very robust method, robust way, and that is only described in the form of a robust method, which is repeatable. So do have your method section, the most strongest one, which can be easily repeatable. And since this is one of the commonest reasons for the rejection of a study, so work on it. So when we say a study which is well planned, is half done, is nothing exaggerated, and that will make you to have your outcome help to the whole community and get your publication done. Thank you so much.
Thank you, Dr. Rakesh.
Sir, can I ask a question here?
Yes, sir, please.
You know, sir, in our in our specialty in chronic pain management, we have very clearly and comprehensively elaborated a few issues, but there are certain more issues, like we have lengthy trials in chronic pain. and there's a loss of patients in between the trials. It's quite common, and we follow. Then we take help of, like, we have take help of the last observation carrying forward principles, and and similar other things. So how far do you justify it? Because sometimes you take the last observations around 4 weeks, 6 weeks back, and then you take it forward.
Right. I think this is a very, very important question, because when we conduct a study and it is say a post-procedural follow-up, maybe for 1 month, 3 months, and 6 months, because of various reasons, maybe the patient expired, or patient have maybe like in COVID, patient were not able to turn up to your pain clinic. So now this loss to follow-up will have lacunas into your data collection. So you will be having missing data. So there are many ways of doing it. We do impute the data for those missing data, or it's called imputation, or sometimes we say last whatever data is collected is carry forward, assuming that probably they remain the same. But remember that these are just the fillers. They are the statistical tool to exaggerate your data that you have collected for the missing data. So these are not the good things. And that is why I come back to the method section. So when you plan your study, you should be very, very clear from your personal experience that when you conduct a study in this group of population, in my clinic, my experience in pain clinic, how much patients do have loss to follow-up. So if I know that out of 10 patients, usually 2 patients will loss to follow-up because they are coming from far-flung area. So when I plan a study, so I will include something into it that will avoid this loss to follow-up. And that something would be whether I will exclude those patients who are coming from outside Delhi, because I know that those are the patients who have a loss to follow-up. Or I will include those patients, like for example, I was just doing a study. So I will know whether I should recruit this patient. So I just check the data from my pain record that any patient who has a regular 6 follow-up in my pain clinic, then only I will include into my study. So this means you can see the regularity of those patients, or you can ask the patient, is it comfortable for you to have a regular follow-up with us? So in that sense, we can exclude those patients who has the propensity of getting lost to follow-up. Obviously, when I say this, there is a newer term which is now coming up, something called pragmatic study. So when we try to exclude those so many things, the outcome may not be generalizable. So we have to balance both aspects of it. The imputation or last data carry forward is just an way of doing it when we don't have any other thing to do it. But it should be avoided by a robust method section and selecting our population so that this can be excluded, one. And secondly, we can always increase the sample size based on our experience of loss to follow-up. So if we know that approximately 1 in 10 is loss to follow-up, so we can increase that sample size by 10, and then we can go forward. And
yes, the same thing I just want to emphasize here, just in continuation, you just said, like we usually keep our sample size, and that's very common with our students also, at 80%, and strictly at 80%. Somewhere it comes out usually, I don't know, usually between 25 to 30. That's a that's a rosy figure that most of our PGs, they come out, sir, we kept 25% or 30%, and this is at for it. So once we conclude the study, this happens, and then the power goes down. So instead of follow this 80% principle, as you said, initially you add 10 or 10% of the population to your group, considering that they could lead to loss to follow-up during your 6 or 12 weeks follow-up period. So I think that could decrease the confounding factors, and that is there. Thank you so much for it.
Thank you so much. With the permission of chairperson, can I move to the next session, please?
Thank you so much.
Thank you, Dr. Pradeep Bhatia and Dr. Hamad Usmani, for sparing the time. Now we move to yet another very important session, and we have 2 very eminent chairpersons with us. We have with us Dr. Ramkumar Venkateshwaran, who is the editor-in-chief of the Airway Journal, the official journal of All India Difficult Airway Society. He is the professor and head, ex-professor and head of the Department of Anaesthesiology at KMC Manipal. He was the director of Medical Simulation Center. He is also the founding chairman of All India Difficult Airway Association, which has prepared the first airway Indian guidelines. And he has a special interest into airway management, medical simulation, and respiratory therapy. Welcome, Dr. Ramkumar, sir.
Thank
we
you.
also have Dr. Asha Tyagi with us. She is a well-known academician, clinician, and researcher with full of knowledge. She is director professor at the University College of Medical Sciences, my alma mater, and DTP Hospital. Welcome, ma'am, and over to you.
Thank you. Thank you so much.
Well, thank you. At the very beginning, I'd like to thank the Indian College of Anaesthesiologists, particularly Jayashree, Rakesh, and Sanish, for having invited me to be a part of this wonderful webinar on essentials of research and publications. We've had two excellent sessions this far. We've had Dr. Pradeep take us through how to frame our research question. And then Rakesh, in his usual inimitable style, has taken us through the planning of a study and the methodology that is involved. And having come this far, we now have to look at how do we collect data and how do we interpret the data that has been collected and look towards the results of the study. And to do this, a very important part of research and publications, we have none other than Professor Sandhya, who's a professor at the PGI Chandigarh. Her areas of interest are pediatric anesthesia, resuscitation, teaching and training, of course, like most of us who are on this webinar, we all love teaching and training, and of course, research methodology. And that's the reason why she's part of this very elite panel on essentials of research and publication. Over to Dr. Sandhya.
Thank you, sir. Thank you very much. I also thank ICA and Dr. Rakesh Garg and Dr. Sanish for inviting me to this webinar. Now, I'm going to talk about data collection and interpretation of results. Now, the initial part of research question and a little bit of review of literature and methodology has been dealt in a very lucid way by the previous speakers. So I'm going to talk about data collection. Data analysis will be held in the next lecture, and I'll also talk a little bit about interpretation of results. Now, my job has been made a little easier by the previous speakers because they have introduced a number of terminologies which are used in research methodology. Now, data collection is very important because it is the quality of data that determines the outcome of the study. As you know, we can have qualitative data or quantitative data, but the data should be accurate and should be of high quality to have a good outcome of the study. Now, when we have a qualitative research study, the type of information that we collect includes knowledge or attitude or practices of people. We also can collect data such as quality of life, functional status after a disease, etc. Now, what do we do with this type of data? It can be used for further research. For example, if you have ICU patients who have been discharged and sent home, you can send them a questionnaire to see what is the quality of their life. And based on that, you can do some further research, or you can have a survey about the knowledge of regarding certain guidelines. Say an association has published to its members, and based on that, if you find something that the members are not aware of the guidelines and their knowledge is not good about it, then they can have a follow-up study, or they can have a change in their policy and try to spread about the awareness of the guidelines. So the data which is collected from qualitative studies can be used for administrative purposes. It can be used for policy making. Now, how do we collect qualitative data? It can be collected by surveys of various types or by in-person interviews. Now, paper surveys were very common till some years ago, but over the years, surveys by phone or email or web-based surveys have become very common. Now, these methods are very easy and very economical to do because a large population from a wide geographical area can be included. in a very short period of time. And this type of surveys have minimal ethical concerns as they are non-interventional. However, they have their own limitations because the response rate is usually very low when you have a survey. There can also be a selection bias. For example, if it is a paper survey, then your participants would be only those who are literate. Illiterate people will not be able to participate. Similarly, emails and web-based surveys will be limited by the availability of internet to people. Now, in-person interviews provide much more quality of data, and but however, they are very time consuming and also expensive, and at one time you can reach much fewer people. Now, what do we use to collect the data? We generally have either a questionnaire, which may be either web-based or a paper-based, but the quality of the data that you get depends on the type of questions you have in the questionnaire. So the questions should be formed with a great degree of thought behind them. They should be appropriate to the research question. They should be very clear and easily understood. They should be not biased in the sense that they should not try to point towards one type of answer. In addition, they should not be double-barreled, meaning that the question should not have one question should not have two questions, and with the possibility of giving only one answer. Or they should not be double negatives, because that can be very confusing and the answers will not be very clear. Also, leading questions should not be asked. Now, the responses to these questions, they can be either close-ended or open-ended. Close-ended means that you have something like a defined outcomes, and you select which outcome is appropriate for you. So they can be dichotomous, that is yes or no type of answers, or they may be Likert scale like of responses, where you have 4 or 5 responses with various degrees which are there. These are very close-ended questions like this are very easy to answer, and there are more responses when the questions have close-ended answers. But open-ended answers are also required because you do get some more details from the responses when there is an open-ended question. And also some part of the question or the research question may not have been addressed in the responses which are listed. So in that case, it's always a good idea to have a mix of open as well as close-ended questions in a questionnaire. Now, there are many standardized validated questionnaires or tools available which you can use. For example, you have questionnaires for quality of life, questionnaires to assess the mental status. So these are standardized tools and these can be used. When you use them, the advantages that you can assess the changes which are occurring in a person after treatment over a period of time. You can also compare the data from different studies. However, there is one thing we must remember when we are using these standardized tools, that these tools have been validated in the language where they were developed. So if you want to use them in patients who do not speak that original language, like most of the tools which have been developed in the West are in English, and we want to use them in India, then we must get them translated. We must take permission, translate them, and validate them before we use them. Because the language of these tools is very important, and so we have to take that precaution. Sometimes a standardized tool is not available and we want to have a new tool. then a new tool can be constructed. However, it has to be constructed carefully so that it answers the research question. And after construction, it has to be validated by experts in the field and retested in a small pilot study before you actually use it for the study. So these precautions have to be taken so that the tool becomes a validated tool. Now coming to quantitative data, these are the various components about the quantitative data that I'm going to cover. Some of them have been touched by the earlier speakers. Dr. Rakesh did talk about the types of data. Now we need to know about the types of data because only then we can know whether the data has been presented appropriately and that it has been analyzed appropriately. So commonly we divide them into continuous and categorical type of data. The common continuous type of data can be on interval scale or ratio scale, or it can be discrete. Interval scale is things like height and weight and blood pressure when the successive measurements are equidistant from each other. For example, if my weight is 55 and somebody else's weight is 56, then there is a difference of 1 kg between the two. Similarly, the difference between 61 and 62 is same. Okay, so that is the property of an interval scale, and there are methods in statistics which can be used for data on this type of scale. Then you have ratio scale. Here the two measurements on the scale, the successive measurement can be compared in a ratio. For example, when the most common example for this is pH. So when we compare pH of 6, the solution has 10 times more hydrogen ions as compared to solution with pH of 7. Similarly, decibels. 8 decibels is 10 times louder than 7 decibels. And Kelvin scale of temperature is also falls on this ratio scale. Now, when we can also have data on discrete scale, where when the specific values are there in finite scale. You cannot have, say, for example, number of children. You cannot have 2.5 children. You have round numbers. You have 2 or 3 or 4 children. Okay. Similarly, in studies, we do count number of boluses of rescue analgesic given. Okay. Again, there are usually discrete values, 2 boluses, 3 boluses, because we have defined that a bolus will be given at a specific intensity of pain. So you don't give half a bolus. Okay, so these are the types of continuous data. Now there can be data on categorical scale. Nominal scale, when they just have there are different categories, but there is no order to them. For example, we can see who are the participants who are attending this webinar, where they belong to which state. So if we describe the participants based on the state to which they belong, there is no order to the state. We can just say, okay, so many % from Delhi, so many people from Tamil Nadu, and so many % from Maharashtra. But there is no order to them. So this is nominal data. They can be dichotomous data when there are just 2 categories, like dead or alive, or male or female. Then there can be a categorical data which is ordered. It is not a continuous scale, but the data is ordered, such as mild, moderate, severe pain. This ordinal data can also include data which is in numbers, which is expressed in numbers. For example, VAS scale for pain, ASA physical status, or GCS. There are numbers in this data, but still it is not a continuous scale. So the statistical analysis for these data should be done in a different way. Now, sometimes what is done is the continuous data is collected, but then for ease of analysis, it is collapsed into categories. You measure the exact blood pressure or age is recorded, but then you collapse them into different categories and analyze them. Now, this results in loss of data, and it is not recommended. It is also a loss of time and money and effort. Continuous data has more power. It can be analyzed more flexibly. However, there are times when we do need to collapse data for the purpose of management. For example, if you want to standardize the management of, say, neurotrauma patients based on Glasgow Coma Scale. So you do form categories based on the GCS of the patient. So in such a case, you do collapse the continuous data or collapse the ordinal data into categories. But all this is based on scientific evidence. It should be done only if you have some reasonable evidence and if it is going to improve the management plan. Otherwise, it is recommended that you use continuous data as such. Now, what is the variation that we talk about when talking about data? Now, normally all biological factors have normal biological variation. For example, if you measure blood pressure in the same person, it will be different at different times of the day. Blood sugar is different at different times of the day. If you measure these data in different people, again, there will be a variation. And there is a normal range within which these things fall. So we should be aware of the variation. And for the same reason, when a measurement is made, the conditions in which the measurement was made should be predefined so that the data can be compared. And these measurement, this is biological variation. Then there can be measurement variation. Measurement variation occurs because of the either your measurement tool or because the conditions in which you have measured is not been specified. Mostly we measure the variation by standard deviation or interquartile range or variance. Now, other things about data which we must talk about is accuracy and precision. Accuracy is how close an actual value is, how close to the actual value your measurement is. Okay, how close to the truth your measurement is, that is accuracy. Precision, on the other hand, is when you measure something repeatedly, multiple times, then how near these values are to each other. So when different people are measuring, then it should be, if it comes out to be close, then the data is precise. It may be measured by different people at different times. So precision is also called repeatability or reproducibility. And similarly, inter-rater and intra-rater reliability. These things are, you can understand what inter-rater and intra-rater reliability means. And it is also called consistency. Now, this picture will give you a little more clarification on what accuracy and precision means. The A shows that all the points are very close to the target, and they are close to each other and they are close to the target also. So that means the data is both accurate as well as precise. However, in the figure B, you see that they are close to the target, but they are not really very close to each other. So the data is accurate, but not really very precise because all the readings are not close to each other. The figure C shows that the data values are very close to each other. So that means they are very precise. If you measure them repeatedly, they are close to each other. However, they are a bit away from the actual value or the target. So it is not accurate, but it is precise. Whereas figure D shows that the data is neither accurate nor precise. So our aim is to have accurate as well as precise data. Now, how do we enhance the accuracy of data? So our measurement methods should be standardized. If we are using some instrument, it should be refined, it should be well calibrated. And instrument doesn't just mean an equipment in a lab or in the hospital which we use to measure something. Instrument also mean things like various scoring systems, various questionnaires that we use. So all these form part of instruments. So we should use well calibrated and validated instruments. In addition, the observers also need to be trained. So that is going to improve the measurement and enhance the accuracy of data. Similarly, if we make repeated measurements, and then it's a common method we use, that we take 3 readings and take a mean of the 3 readings. So repeated measurements can be taken. In addition, my previous speakers have already talked about blinding the observers as well as the subjects. That also improves the accuracy. We can use unobtrusive methods. For example, if you're trying to assess pain in a child using an observational scale, you can do it quietly, so without the child trying to noticing you, because if you are coming close to the child, he may anyway become very restless and unhappy, and you will not be able to get the correct idea about the pain. So you can use such methods. In addition to measurements, then data entry and analysis should also be done in a proper way so that the data entry is accurate. Now, just a word about validity of measurements. There are various components of validity of data. There is construct validity, which means that the exact it matches what you are trying to measure. Content validity is when you include all the relevant aspects of what you want to measure. External validity is generalizability. That means that it can be measured, the same instrument can be used not only where you are conducting a study, but in other population also. Then there is criteria validity, basically in which you compare your method with the gold standard, if there is a gold standard available for that particular measurement. So all these things will improve the accuracy of measurement. Then the method of your measurement should also be responsive. It should be able to assess the changes that occur as the conditions change. Some may, we must know which ones are not very responsive. For example, NYHA class is not very sensitive to subtle changes in patient's condition of CHF. When you're assessing neurological changes in patients in ICU, 4 score may be better to assess the daily changes as compared to GCS. So 4 score is more responsive as compared to GCS. Now, errors in data collection has also been talked about earlier, but I'll just very briefly describe this. Random error is something which occurs by chance and it is not predictable. So there is something which there's nothing we can do about random error. However, the systematic error or the bias is something which we should try to reduce during our data collection. So it doesn't occur by chance, but it is introduced by inaccuracy of the measurement process. The source, as we have mentioned earlier, it can be the instrument, it can be the observer, or it can be the subject. If you're trying to find out some details from the subject about, say, duration of medication or his previous investigations, and he may not remember it correctly. So then again, that will lead to some source in that will be a source of error. Again, data entry mistakes can occur, and that will introduce error in our final analysis. So when data entry is being made, it should be standardized. It should be done in a way that it is simultaneously checked that no false entries, wrong entries are being made. You can have specified criteria when the entry is being made, so that only the options which are available, they can be entered, and so that avoids a wrong data entry.
2 minutes, ma'am.
So coming to the interpretation of results. Now, interpretation of results is, we have to assume that the methodological rigor has been followed throughout the process of data collection. We have various, the data is presented in not just the point estimates, but variability such as standard deviation and interquartile range has been presented. Now, this has been mentioned earlier, but I'll re-emphasize that the outcomes should be pre-specified. The primary as well as secondary outcomes should be pre-specified. And the surrogate endpoints, it is not recommended that you use surrogate endpoints, but the endpoints which are of clinical relevance should be studied.
Dr. Sandhya, you have 5 minutes to go, please. Thank you.
Okay, sir. Thank you. So another problem which occurs commonly is that sometimes we do not find a positive result, in the sense that we expected some difference between the two groups. We do not find that difference as far as one outcome is concerned. So we try to analyze a large number of outcomes, and that is called data mining, and which is not the right thing to do. So what we should do is we should pre-specify the outcome that we are going to analyze and report the results. Also, whatever tests we have done, if we have conducted some extra tests on different outcomes, we must report all the tests. If multiple tests have to be done, we should specify, and we should also adjust the sample size and significance level before the start of the study itself. It's very important to report the adverse effects. There is no treatment, no intervention, no screening test which is devoid of adverse effects. So all adverse effects should be specified, pre-specified, and their frequency and severity should be reported. Causation and association is often confused. Observational studies, they usually, the information they give us is about the association of exposure and outcome. They do not give evidence of any causation. So this is something we should understand, and we should report it as such, that there is an association between such and such exposure and outcome. And the causation will have to be dealt with in later studies. P-values give us a very narrow perspective, in the sense they just tell us whether the null hypothesis can be accepted or not, whether there is a difference between the two studies. They do not tell us about the effect size. They do not tell us in which treatment group the effect was more or less. So what we need to do is report something more than that. And we should always give the actual p-values whenever we are reporting. So the effect size should be presented. The variation and confidence interval should also be presented. Confidence intervals is the range of values which we derive from the data, which we calculate from the data, within which the truth lies. Okay. And there is some specific probability depending on the confidence interval that we have chosen. So it should be reported for our outcomes. It not only gives the whether the data is significant or not significant, it gives us the upper bound and lower bound of the effect. It also tells us the magnitude. So it gives us the magnitude, and which makes us interpret the results in a better way. I'll just skip these examples of confidence interval because of shortage of time. The other method of effect size is absolute risk reduction. The difference in the risk between the two treatment groups can be presented as absolute risk reduction. A larger risk reduction will tell us that the intervention is very effective. Numbers needed to treat is just the inverse of ARR, and either of these can be used to present the effect size. Now, before I sign off, I'd like to say that statistical significance and clinical importance are two things that we must keep in mind. Statistical significance does not necessarily mean clinical or policy importance. So there may be small differences of no clinical importance, which may show to be statistically significant in very large samples. Similarly, clinical important effects may not show as a significant result. For example, if you're talking about, if your outcome is mortality, even a small difference in mortality may be of clinical relevance, but in a study, it may not come out as a significant result. So these are the things that we have to keep in mind when we are interpreting the results. I will not talk about type 1 and type 2 errors. This has been described earlier, but I'm sure if you remember these two pictures, you will remember what type 1 error is and what type 2 picture is. In the first picture, this is a type 1 error, that is a false positive. This man is definitely not pregnant, but has been diagnosed as pregnant. Whereas in the second picture, it is a type 2 error, that means false negative, where the woman is definitely pregnant, but she is being told that she is not pregnant. So you remember these pictures. So when you are making conclusions and making recommendations regarding a treatment after analysis of the data, you must remember to mention the size of the treatment effect. You must also mention what are the potential for harm. Financial cost should always be taken into consideration, though we haven't described it here in this lecture. Patient's experience of the intervention should be taken into account. For example, if one treatment includes giving injection, though it gives a larger benefit, and the alternative is an oral medication with a slightly lesser benefit. Some patients may prefer to take an oral medication, even if they have to bear some amount of pain. So patient's experience is an important component and should be always kept in mind. Generalizability or external validity to other set of patients should always be mentioned when we are making conclusions, because your findings may be limited to the set of people that have been included in your study. So to conclude, I would say that data interpretation is a conscious effort. Many aspects have to be taken into consideration, and at the center, always keep the basic primary hypothesis in mind. Thank you.
Thank you so much, Dr. Sanjay. I think we have time for a quick couple of questions. One we received in our chat box, and somebody wants to know what is the status of survey-based studies in the evidence-based pyramid. And in the same breath, it is also asked that how much response rate would you probably consider adequate to have meaningful results, let's say the survey or feedback kind of a study?
Okay, survey-based studies are basically opinions and such things. So they are not at, they are actually at the bottom of the pyramid. But I would say no study is useless. Even the studies which are at the bottom, they do form the base of the pyramid. So they are important. Okay, so because based on the outcomes of these, we form later studies which are more robust. So these studies are required. It's not that they are not required. And how much response rate is adequate for meaningful results? Probably the question means that when you send out a survey, how many should respond? Is that what the question is?
Probably that is what is being meant.
It is. I don't think there is a hard and fast formula for that. Okay, it will depend on the type of people you are approaching. Okay, suppose ISA is conducting a survey and it sends questionnaires to its members. It's more likely that a lot of people will respond as compared to if I, as a member alone, I send a survey, maybe fewer people will respond. So there is no hard and fast rule for that. You have to account for the response rate when you are planning the study. That will make
I think that would be a fair, And one more question, I think, which you already answered during your talk was, someone had put in a query that what is the difference or how to interpret a variation between statistical and clinical significance. The more pertinent query was that should it be left to be decided by an expert, or can the author decide to take that decision whether it's clinically significant or not?
Yes, when one person is conducting a study, that person is an expert in that area because he does read up the literature. He has some experience in that field. So based on his experience and his review of literature, he decides that what is relevant, and based on that he decides upon the sample size, he decides upon the methodology. So most of the times, yes, if it has been, the study has been properly designed, a statistical significant result should also be clinically relevant. But it does happen that many times we have a lot of limitations, especially for PG thesis, etc. We have limitation of time and the number of patients we can include in a study. So in such cases, even if you find statistical significance, suppose you are talking about time taken for intubation and there is a difference of 2 seconds or 3 seconds, but it comes as statistically significant. It really doesn't have any clinical relevance. So we should be able to accept that when we are writing the results and discussing. So we should be aware of these things. That's all. We should not just close our eyes to the clinical part and just talk about statistical significance.
Sandhya, thank you very much for a very wonderful lecture. I think all three speakers have done great justice to their topics, very vast topics, and therefore I felt very bad to stop you. I'm sorry about that. We were doing
That's
great.
Fine.
But we had to stick to overall time just so that we finish on time. I just one last statement I'd like to make is that very often it's true that clinicians are not very good statisticians. And the statistician we go to may not know much about clinical matters. That's always a problem because we don't have too many departments which are led by medical statisticians. Very often we go to a general statistician and they don't understand the clinical importance of what we are studying. Nor does a clinician understand the statistics as well as they do. So very often we get back a lot of data and then we have to sift through a lot of data. So I think it's a good idea for a thesis guide and the postgraduate to do something like an eyeballing of your results. And you see, you must go to your statistician with a preformed idea of what we need to, what results you want from the statistician, and not just say do everything that's possible. So I think when everything that is possible is done, then we get reams and reams of paper, and then we do not know what to throw out. That's the problem. You have to have some idea when you go to the statistician.
The best thing would be to include the statistics should form part of the methodology. So a detailed methodology, like Dr. Rakesh Garg said very rightly, that methodology should be very, very detailed, and that includes the statistical analysis. So we must know what we are going to, what are the outcomes we are going to study, and how we are going to analyze them. So it is very important for all of us to be familiar with statistics. It is not very difficult, but the basics of statistics, all of us who call ourselves researchers should be aware of. So then it becomes very easy, and communication with the statistician also becomes very easy.
Absolutely. Thank you very much, Dr. Asha, as well, for helping us. Thank you.
Thank you very much.
Go on to the next person. Thank you.
Thank you so much, ma'am, Dr. Sandhya, and thank you so much, Chairperson, Dr. Ram Kumar sir and Dr. Asha Tyagi. Thank you for sparing. And moving to the next session, we have eminent chairperson for this session, Dr. Indrani Hemant Kumar. Madam is a well-known personality in the field of anesthesiology across the globe. She is the head of the department at KEM Hospital and St. G.S. Medical College, Mumbai. She is president of Research Society of Anesthesiology and Clinical Pharmacology. And she is very popular in extracurricular activities also we could see at various platforms. So welcome, ma'am, and over to you.
Thank you so much, Dr. Rakesh, for that introduction. It's my proud pleasure to introduce Dr. Anirban Home Chowdhury. He is a professor and in charge of critical care of GB Pant, PGMER, and he would be talking on basics of statistical tools.
Thank you, madam.
Over to you, Dr. Anirban.
Yeah, thank you, madam, for the kind words. And since we are on the last over in the slog overs have started, I won't take too much of time. So I will move. Initially, I wish to thank Dr. Rakesh and Dr. Sanish for giving me this opportunity. And I will move on straight into the subject. So the topic on which I am talking about is the statistics, which has to be understood for an average researcher, not for the very advanced researchers. So whenever a researcher conducts a research, he is interested in a target population. And whatsoever he wants to know, he knows about the target population and he wants to be valid for the target population. For example, if I want to know what is the average blood sugar level of the diabetic people, so I wish to know the diabetic of all the diabetic people, patients in the world. So the right method of this is to trace out all the diabetics of the world and measure their blood sugar and see their average, which is not possible. So that is why we do a test on the samples, who are the representatives of the target population. So when we choose a sample, we know that every member of the population has the same chance of being selected in the sampling, and that is why there are different sampling methods. I'm not going into that. Now, whatever we derive from the sample gives us the data, and from this data we get the statistics. Now, a part of this statistics is the statistics of the data that is within that sample, and based upon that we give an inference on the parameters that is true for the entire target population, which covers outside the sample also. So the first one, which describes the data, is the descriptive statistics, and the one which infers on the target population based on the results of the data of the sample is the inferential statistics. So descriptive statistics is concerned with describing the target population, and inferential statistics is to make inferences from the sample and generalize them to the population, where our interest is in actually. So descriptive statistics organizes, analyzes, and presents the data in a meaningful manner. Inferential statistics compares, tests, and predicts the future outcomes. In descriptive statistics, the results are shown in the form of charts, tables, graphs, etc. And whereas in inferential statistics, it is spelled out in terms of probability scores. Descriptive statistics depends upon the data which is already known, because that data has been derived from the sample. Inferential statistics try to make conclusions about population which is beyond the data available. So there are certain tools for descriptive statistics and there are certain tools for inferential statistics. So let us first start with descriptive statistics. Descriptive statistics, we have two measures. One is the measure of central tendency and another is the measure of dispersion or variation. Measures of central tendency means the extent to which the observations, of course, I mean the data, cluster around the central location. So how much closer to the central location? Now, this is given by four things. One is mean, median, mode, and quartiles. The second is the variation. That is how much these observations spread towards the extremes. Now, this is called the variability. And there are three measures of variability: standard deviation, variance, and range. Mean is very simple. It is a measure of central tendency. We calculate all the values in a data set, divide them by the total number of values. That gives us the mean. So this is the most commonly used way because it is easily understood. It possesses useful mathematical properties and it is convenient for use in various statistical contexts. But one problem with mean is that it is strongly influenced by extreme outliers. So when outliers are present, it can go very high or it can go very low. For instance, if we 20 anesthetists are sitting in a room, suppose we have an average monthly income of X. Suppose after a while, Ambani comes and takes a seat next to us. Suddenly our mean income will go several fold. So this is the problem with outliers. So this is mean is most representative when the data are symmetrically distributed. I will come into what they mean by symmetrical distribution later. All the part of it has been explained. Next is the median. Whenever the values are sorted in order of their hierarchy, the central value of that observation gives us the median. So if there are odd number of observations, then it is simply the middle value. Suppose we have 5 observations, 1, 2, 3, 4, and 5. So the middle value is 3. So median would be 3. If there are even number of observations, then it is the average of the middle two. Like if I have 4 observations, 1, 2, 3, and 4, then it should be the mean of 2 plus 3. 2 plus 3 divided by 2. So it will be 2, the median would be 2.5. So mean is 3, median is 2.5. So this median does not have all the beneficial mathematical properties of the mean. But good thing about median is that it is generally not influenced by extreme values or outliers. And it is particularly useful when there are unusually low or high values which render the mean unrepresentative, like the example I cited just before it. The third measure of central tendency is the mode, which is the most commonly occurring value in the data. It is generally not of much use except particularly when the data set is small, but it has certain values when the large data set. And it is because it is not representative of the data always, so it is avoided in cases of small data sets. For example, these are my hemoglobin levels of my 48 patients in the ICU. So if you look into it, I calculate all of them divided by 48 by 9.9. 9.9 is by mean. So the 48 is an even number. So I take the mean of 24th and 25th. So mean of 9.7 and 9.9. So 9.8 I get, this is the median. And then I see which is the most frequently occurring value. And I see that it is 9.4. So 9.4 is the mode. So that is the measure of the central tendency. Now all this can be plotted along this graph, which is called the frequency distribution. So if we include a frequency distribution, we get some kind of curve in the middle of which we will get all these values of mean, median, and mode. Now next is the measures of dispersion or variation. So first thing in the measure is known as the range. Range is nothing but the difference between the largest and the smallest observation in the data set. Now, since it is based on only 2 observations, it may not be representative of the whole data set. It gives no information regarding how the data are distributed between these 2 extremes. Therefore, a better way to express is an interquartile range, which is the observations in the middle 50% of the observations about the median. I'm giving the example how to calculate. Suppose we have these numbers in order 1, 2, 5, 6, 7, etc., etc., up to 27. First, we find the median. So here we find that the median is 9 after arranging them in order. So there are certain preceding numbers to 9, that is 1, 2, 5, 6, 7, and there are certain succeeding numbers. So the preceding numbers, here the median is 5, and the succeeding numbers have the median is 18. So when we subtract 5 from 18, that gives us the interquartile range. So interquartile range will be 13, although the range of the numbers is 1 to 27. Now, this is a very simple example. The example becomes difficult as we move towards the advanced stats, but I'm restricting it just for the clarity of understanding to the postgraduates. The next to range and the interquartile range is the standard deviation. Standard deviation is the degree to which the individual observations in a data set deviate from the mean value. Broadly, it is the average deviation from the mean. So whenever we talk about the mean is expressed in terms of X bar. So if we have various observations, X1, X2, X3, we calculate each of them, X1 minus X bar, X2 minus X bar, X3 minus X bar, up to Xn minus X bar, like that, square of that. And after that, we divide it by n minus 1. N is the number of samples, n minus 1, and the whole thing, or the square root of it, gives us the standard deviation. Now, why it is made square? It is made square to negate the effect of minus values. Suppose X1 is less than X bar. So that will, if I don't put a square, so that will create problem in while adding. So that is why it is used. So the whole thing gives us the standard deviation. Next is the variance. Variance is nothing but the square of the standard deviation. It is not generally much used in the data, but it is central to the analysis of variance, which is an important test. Now, whenever we express our data, it is expressed in terms of, suppose we say mean plus minus standard deviation. Why we say that? Because mean is the measure of the central tendency. Standard deviation is the of the variation or dispersion. So we again, median plus interquartile range. Median talks about the central tendency, interquartile range talks about the dispersion or variation. So that is how in statistics we express the descriptive. Now I'm using the same data set. So my values are 48 values. So here my range would be 5.4 to 14.1, easily understood. To calculate the interquartile range, see, it is a 48 is a even number. So we have to take the mean of 24 and 25. Mean of 24 and 25 is 9.7 plus 9.9 divided by 2. So it is 9.8. So all the numbers which are preceding 9.8, we check the mean. That mean we calculate. So it comes out to be the mean of 8.6 and 8.8. So it is 8.7. And on the right hand side, again, we calculate it is 10.8. So the difference between 10.8 and 8.6 gives us the interquartile range. Like similarly, we calculate all the values from the like 5.4 minus 9.96. So like that, we can get the standard deviation. So this is a very simple thing. Now we use software. So softwares automatically check out. We don't have to do the calculations. Earlier people used to do. Now it is not required. Now this is something important because whenever there is a normal distribution, we talk about mean. Whenever it is, what do you mean by normal distribution? Normal distribution means that they are, when we plot these observations, they're equally distributed on both sides of the mean. So here the mu is the mean. So 68.46% of the values will be within one standard deviation of the mean. 95.46% of the values will be within two standard deviation in the mean. 99.73, so it will be within three standard deviation of the mean. So we get two equal sized tails on both sides of the mean. So this is what is known as the normal deviation, normal distribution. So ideally, if we talk about normal distribution, there is absolutely no skew. Then mean, median, mode will all be in the same line, or they will be same. Now, such an ideal situation is not found. So always there is either the left tail or the right tail becomes slightly longer. So depending upon the direction, it can be either negatively skewed or it can be positively skewed. So accordingly, the median, mode, and they will keep changing depending upon the extent of the skew. So when the distribution is normal, we do one kind of test. When the distribution is abnormal, we either convert them into normal distribution by logarithmic transformation or do the non-parametric tests. Now, this was all about differential statistics. Now I am coming to the inferential statistics. In inferential statistics, I have already told you, I am inferring on the target population. Now, this is based on two things. One is estimation. Estimation is we generalize to the whole population, taking into account that our estimate is approximate. That is, there is a margin of error, or that it could be completely wrong. So if our sample is exceptionally different from the population, so there is called the probability of error. So margin of error and the probability of error, these are our estimation. Now these follow a particular set of tests. And the second is the hypothesis testing. We have already talked about hypothesis testing, that there are two kinds of hypothesis. Null hypothesis, conventionally we deal about. Suppose we have two drugs, A and B, and both are on COVID. And so we say that the drug A is better than drug B. So we can say that in the null hypothesis, we'll say that there is no difference in the efficacy between drug A and drug B of this of COVID. So if that becomes an alternate hypothesis, it will be drug A is different, has a different clinical efficacy on COVID than drug B. So depending on that, we either accept the null hypothesis or will reject the null hypothesis. Now, we have already heard about it, that how we accept and what is the p-value. What is the important to know is that when the statistics plays a crucial role is to know that the sample size, because sample size is directly related with the power of the study. Now, study must have an adequate sample size related to the goals and the possible variabilities of the study. And if the sample size is not adequate, the power is weakened, because power proportionately increases because as the sample size increases and the vice versa. So power is the probability of correctly rejecting the null hypothesis that the sample estimates does not clinically differ from between the study groups in the underlying population. So if for that, the study should be adequately powered. So this is dependent on the sample size. So investigator can control the study power by adjusting the sample size. Now this sample size has different calculations. One, it can be estimation for proportion. So that is again one sort of formula. P is the prevalence. So whenever we want to calculate the sample size and we discuss it with our biostatistician, we have to actually present with them, where he will ask us that what is the prevalence of this. So if I say that we don't know, then he will not be able to give us the sample size. So either from the pre-existing studies, we should know the value of P, or by doing a pilot study, we calculate the value of P and then give him the P. Then what is the level of significance to be attached? What is the precision? What margin of error? So all these inputs are necessary from the clinician to the statistician, without which the statistician will not be able to give you the sample size. Now D is the design effect, and this design effect will vary according to the design which is used. In survey it will be one, in RCT it will be another, likewise. For example, let us take an example. What is the sample size for measuring the prevalence of obesity in a certain, suppose obesity in Delhi. So previous literature gives us the estimate of obesity as 20% in the population to be surveyed, and assuming 95% of confidence interval or 5% level of significance, and assuming a 10% margin of error. So we apply this formula, or it can come from the software also very easily nowadays. Just have to be, and we get this a number. So sample size of 1537 is required to conduct this community-based survey. So there is a margin of error. So this after that, for the finally adjusted sample size, we should allow some non-response rate, because everyone will not respond to the survey. So that also we will have to add. So suppose we add 10%. So likewise, we get a sample size to calculate the prevalence. Again, the sample size can be estimated between the single grouping. Again, the formula will change, but the rest of the things remains the same. So we need to know the standard deviation obtained from previous study or a pilot study. What is the accuracy of estimate and how close it is to the true mean, and Z alpha by 2, that is the normal deviate with the two-tail alternative hypothesis. Two-tail hypothesis means that it can go in either direction. If I have two drugs, A can be either better than B, or it can be same as B, or it can be inferior to B. So it can move in either direction. That's why it is called it two-tailed. So when we calculate it basis upon the two-tailed or one-tailed observation. So similarly, if it is a sample size estimation with means, we will have a different formula. But again, we will have to give the inputs. So that those depending upon the inputs, depending upon the margin of error, depending upon the level of significance, so we will get the sample size. A researcher wants to compare two drugs on systolic blood pressure. On literature search, he found that the systolic blood pressure in two groups were 120 and 132. Standard deviation is 15. Those are total sample size with equal sample size. Now, if you want to put equal number of patients in both the groups, so that will have one kind of calculation. And if we don't have unequal, then it will have a, suppose if it is in the ratio of 1:2, like here, then again the calculation will change, because this R plus R, this value will be 1 plus 0.5. So the value will change. So accordingly, we will can calculate the sample size. Similarly, sample size estimation with two proportions, that was again the different formula, where P1 and P2 are proportion of the event of interest, whether it is mortality, it may be time to recovery, whatever it is. And again, it will be added up or subtracted as usual. Suppose we say that, take an example, proportion of patients who develop complications after undergoing one type of surgery is 5%. Proportion of patients who develop complications after a second type of surgery is 15%. How large should be the sample to be in each of the two groups if an investigator wishes to detect with the power of 90% whether the second procedure has a complication rate significantly higher than the first at 5% level of significance? Now, this is how we will actually have to put the question to our statistician. And in that case, we know that the test value of difference in complication rate is 0. Anticipated complication rate is 5% and 15% in the groups. Level of significance, power of the test, alternate hypothesis, that is one tail, because it is moving in the one direction. One is better over the other. So we calculate. So our sample size calculation becomes easier. So there are various factors which affect the sample size. And if the p-value or alpha level is small, then we need a large sample size. If it is large, we need a small sample size. If the power is large, then identification of more probability, so required sample size is large. Similarly, there is the effect size and alternative hypothesis. We have heard about it in our previous lectures quite some time. Now, p-value, we have already heard about it. I won't like to repeat it, but p-value is a probability which reflects the measure of evidence against null hypothesis, which means the smaller the p-values, the stronger is the evidence. Now, that whether it is 0.05, whether it is 0.01, that is at the discretion of the clinician to decide that how significant it is. So it is not necessary that it has to be always 0.0 less than 0.05. It may not be also. Conventionally, it is chosen as p is 0.05, but it can vary depending upon to consider how much close is your statistical significance is to your clinical significance. Now, to permit a decision making between null hypothesis and alternative hypothesis, significant limits are often specified in advance. So that level of significance is 0.05, and that is why we consider p-value less than 0.05 to be significant. Now, confidence interval, as Dr. Sandhya madam has told already, that is how confident you are. If I ask someone what is your height, and he says that the height is 5'6", then I am telling you next question would be how confident you are that your height is 5'6", and he replies that if my height is taken 100 times, 95 times, the value would be between 5.2 to 5.8. So that expresses his confidence. Another person may say that if you take 100 readings, 95 times, it will be between 5.4 to 5.7. So that's what shows that if it is narrow, his confidence is more. So for confidence levels of 90%, 95%, 95%, so accordingly the Z value that will vary. Now the standard error, so this is the way we calculate the sample mean plus minus Z value into the standard error of mean. Now standard error of mean is nothing but standard deviation by the root of n, where n is the sample. So that will give us the amount of it. So the margin of error depends upon the size and variability of the sample. If the sample is variable, so then we know that the margin of error is small, because the error will be small if it is large. So likewise, for example, let us take the mean systolic blood pressure and diastolic blood pressure of 72 randomly selected patients of more than 50 years is 134 and 88. With the standard deviation is 5.2 and 4.5. What is the 95% CI for the BP readings? So we will consider the sample as a fair approximation to the population standard deviation. So here again, you see the systolic deviation 194 plus minus 1.96. We are taking into 5.2 is the standard deviation divided by 72. So it is 134 plus minus 1.2. Similarly, for 95 of the diastolic blood pressure, it is 4.5. Rest of the things are same. So it comes out to be 86.9 to 89. So likewise, we can calculate the, now as it has already been pointed out, the p-values versus confidence interval, what are the differences? Both have their own advantages and disadvantages. Of course, p-values per se have fallen out of favor these days. We are more relying on confidence interval because CI provides information about statistical significance as well as the direction and strength of the effect. P-value just gives us a number, but it doesn't give us the direction and strength of the effect. This also allows a decision about the clinical relevance of the results. P-values, one advantage is that they are clearer than confidence intervals because they talk about specific things. P.004. It means something. Confidence interval gives us a range. So it can be judged whether a value is greater or less than a previously specified limit. This allows a rapid decision as to whether the value is statistically significant or not. So that is some amount of convenience attached to the p-values. Hypothesis testing using a p-value is a binary decision, yes or no. So that has certain advantages but more drawbacks than advantages. And in contrast to confidence interval, p-values give the difference from a previously specified statistical level of alpha. This facilitates evaluation of close results. So when the results are too close, the confidence interval giving a range, it may not be able to discern them. P-value may be able. Now, whenever we talk about variable, I'm not going into the details. I'm coming to the tests now. We know that we have been told that there are qualitative or categorical, quantitative. Now, quantitative can be discrete when they're in absolute numbers, where there is no decimal, like number of groups, number of doses, number of drugs, etc. Or they can be continuous, like temperature, height, etc. And similarly, the categorical can be either in a following order of hierarchy, like ordered, like mild nausea, moderate nausea, etc., or they cannot be arranged like nominal. So depending upon that, there are certain factors which allows us to choose the statistical methods. So one is the aims and objectives of the study. Suppose our objective is to find out the predictors of the outcome variable. Outcome variable, suppose I'm trying to find out the day between smoking and cancer. So outcome variable is cancer. So if I found the predictors, then a regression analysis is used. Whereas to compare the means between two independent samples, we use unpaired sample treatments. So likewise, the aim and objective of the study is important. Type and distribution of the data. For example, in the regression analysis, when our outcome variable is categorical, that is cancer yes or cancer no, then logistic regression. When our outcome variable is a continuous variable, then say take a different example. Say suppose the blood pressure, the malignant hypertension more than 190, then we use a linear regression. When the observations are paired or unpaired, suppose we have pre-test, post-test, that is fasting blood glucose and postprandial. So we'll say we're paired. So accordingly, compare means between two groups and data is paired. We use paired sample t-test. When unpaired, we have individuals. So these three things are very important. Your aim and objective of the study, type and distribution of the data, and observations. So as I told you, when the data is distributed normally, it is abnormal. So when it is abnormal, we can use the non-parametric methods. When it is normal, we can use the parametric methods. If it is abnormal, we can either convert it by logarithmic transformation into parametric and apply the parametric methods, if that is our way approach, or we can change it. And similarly, there are methods to compare the proportions depending upon the data type. There are also semi-parametric methods. I'm not going into the detail because that is slightly difficult, because they take into considerations few more things which are difficult for ordinary researchers like us to comprehend. But I can tell you one thing, that if you are sure of your input variable, if you know that whether it is nominal, whether it is ordinal, whether it is categorical, quantitative, discrete, etc., and your outcome variable, you can easily know what your tests are. And once you know the test, any software, whether it is Stata, whether it is SPSS, you can find out. If it is nominal, you do a chi-square or Fisher's test. More than two, again you do a chi-square test. Quantitative discrete. So again you do Van Wheating. So likewise, if you see the test, it is not easy, not a difficult thing at all to identify which test is. So if you know the variable, you know the test. If you know the variable is your nominal, and you can choose that it is your McNemar's test. If it is order, so whenever the choice of statistical from paired or matched observation, you can follow that this will only revolve around these four tests. When there are more than two groups, again parametric or non, this will revolve around these are the four tests. So out of these 8 or 9 tests, most of the informations can be obtained. So my take-home message would be that various statistical methods can be used in different situations, and each test makes particular assumption of the data. Two main statistical methods are used in data analysis. One is descriptive statistics, another is inferential statistics. Descriptive statistics summarizes the data using indices such as mean, median, mode, and other inferential statistics derives conclusion from the student's t-test, etc. Selection of appropriate statistical method depends on aim and objective of the study, type and distribution of the data used, and nature of the observations. And basic statistical knowledge is very important to adopt, because correct practices, and more importantly, to recognize incorrect practices. Thank you very much. And I hope I have not exceeded my time limit.
Thank you, Dr. Anirban. You've really simplified a very complex topic. I don't see any questions on the chat box. And anyway, I think
maybe I have
understood.
simplified it too much, madam.
No, this is such an important topic for all the PGs, because when they have to do their thesis, they have to know every bit of whatever you said. And Dr. Rakesh Garg did a fantastic job of doing this webinar, and each and every speaker did a fantastic job of teaching and simplifying research. Thank you very much, Dr. Rakesh, for inviting me, and over to you.
Thank you so much, ma'am, and thank you, Dr. Indrani Hemant Kumar, for coming forward and sparing time. And thank you, Dr. Anirban Home Chaudhary, professor at GB Pant Hospital, for putting a difficult topic in a simple language. So it has been a wonderful seminar. My sincere thanks to all the faculty, Dr. Pradeep Dongre, Dr. Sandhya Madam, Dr. Anirban, for sparing time. And also thanks to the eminent chairperson who are eminent personalities in the field of anesthesia, pain and critical care, for sparing time. I sincerely thanks to all the faculty and chairperson, and also thanks the Indian College of Anesthesiologists for giving this opportunity. So I will request all participants, there is a link here, which is the feedback form. So once you click it, Google form will open up, you fill it up, and on your email, you will get immediately the today's webinar certificate that will be given to your email. So please fill it up. So I will request Dr. Baljeet Singh to give a vote of thanks. Over to you, sir, and concluding remarks also.
Well, thank you, Dr. Rakesh. I must say that it was a wonderful webinar. Wonderful in the sense that, first of all, I compliment all the speakers for the wonderful talk that they have delivered. And this was one area I think we hadn't covered well so far in the ICA webinars that we have been conducting for nearly a year now. Now it is, it was a much needed webinar also, because this area doesn't get as much importance as we give to perhaps other topics related to anesthesia. And whenever it comes to statistics, we generally take it as, we'll do it later, we'll do it later. So it unfortunately, it has started coming into the curriculums only recently. Till a few years ago, it was hardly anywhere in the curriculum, and it's now that it has started coming out, people have started realizing the importance of this. I agree with Dr. Ankumar's comment that, there is some sort of disparity between the understanding of a clinician and a statistician, because statistician doesn't understand the requirements of a clinician, whereas a clinician perhaps doesn't understand the requirement of a statistician, is what kind of data he would need to get the result that we need. Anyhow, I think all the speakers have done full justice, more than justice, I would say, to the topics. Dr. Pradeep Dongre, Dr. Rakesh Garg, and Dr. Sandhya, as well as Dr. Anirban Home Chaudhary, my colleague there in GB Pant till a few years ago. And of course, the moderators have done an equally great job. Dr. Deepak Govil, Dr. Bharti Vadva, Dr. Pradeep Bhatia, Dr. Hamad Usmani, Dr. Ramkumar Venkateswaran, and Dr. Asha Tyagi, as well as Dr. Indrani Hemant Kumar. We have exceeded time by quite a bit. So I think I would like to end it up by saying that I convey profuse thanks on behalf of Indian College of Anesthesiologists to all the speakers who did such a great job, and of course all the moderators who have moderated so very well. Thank you so much, and till we meet again next week on Wednesday. Have a good time and stay safe, and wish you all the very best. Good night.
Good night.